Is the slide share part visible? I mean, slide.
Yes, ma'am, it is.
Yes, ma'am, visible.
Okay. Good evening, everyone, and thank you, organizers, for the opportunity. Before going on to the temporal bone tumors, let us have a brief overall brief anatomy on the lateral skull base, because the temporal bone tumors fall under the broader heading of lateral skull base tumors. So lateral skull base, they are a rare group of disease which remains in very close proximity to various vital structures.
Dr. Kabiri, sorry to interrupt you. Ma'am, can you switch off your fan in case it's on?
So lateral skull base tumors, they are a rare group of disease which remains in very close proximity to various vital structures. The routes of spread are determined by the complex anatomy of the maxillofacial compartment, by the surrounding compartment. It involves a highly specialized set of surgical procedures to treat various conditions, and these field has seen tremendous evolution in the last 20 years. So the lateral skull base anatomy, it comprises of the following bones: mainly the squamous and the mastoid portion of the temporal bone, but also the sphenoid, occipital, styloid process, and the zygomatic arch. For the purpose of ease and better understanding and evaluation of skull base tumors, Irish and his group in 1994 have proposed this classification of the skull base. Region 1 mainly comprises of the anterocranial fossa. The region 2 includes the infratemporal and the pericopulatine fossa with extension to the middle cranial fossa. And region 3 includes ear and temporal bone tumors with possible extension to the middle and the posterior cranial fossa. So this region 3 of this classification mainly comprises the temporal bone tumors, or mainly houses the temporal bone tumors. So as discussed, region 3 involves temporal bone with possible tumor extension to middle or the posterior cranial fossa. These site has vital structures like the IJV, the sigmoid sinus, the lower cranial nerves like 9, 10, 11, 12. And rare tumors from this site might be congenital, inflammatory, traumatic, benign, or malignant tumors. So this is the radiographic pictorial depiction of the temporal bone site. So for today's presentation, we will limit our discussion to the temporal bone malignancies. So temporal bone malignancies, they are a rare group of disease with prevalence reported at just 1 per million. The ear, the external auditory canal, and the temporal bone, they have various structures like the skin, the sebaceous glands, the bone, the cartilage, the nerves, etc. And any of these structures can give rise to tumors. The structures in the vicinity, like the mandible, the parotid gland, the meninges, even the brain, they can also encroach a temporal bone and cause rise to tumors. The mean age group to be affected is mainly the 5th to 7th decade. The etiology of the temporal bone malignancy still remains an enigma, but there are suggestions that the chronic suppurative otitis media or exposure to radiation might have a carcinogenic potential. Squamous cell carcinoma is the most common histology. It can spread via various routes to the surrounding structures. It can spread anteriorly to the temporomandibular joint, the glenoid fossa, the ITF, the parotid, and can give rise to a preauricular swelling. It can spread inferiorly to the stylomastoid foramen, giving rise to facial nerve palsies, to the jugular foramen, giving rise to the lower cranial nerve palsies. Medially, it can spread to invade the tympanic membrane, the middle ear, the inner ear. Superiorly, it can cause erosion of the tegment tympani and go to the intracranial site. And posteriorly, through the mastoid cells, can invade the posterior fossa. So these are the various routes by which the tumor can spread. The nodal metastasis at presentation is not very high, it is less than 10%. The first echelon nodes are intraparotid nodes. However, as in all other head and neck cancers, nodal involvement is considered to be a bad prognostic factor, with survival dropping from almost 60 to 30% with positive nodes. The distant spread is rare and can involve the lung, bone, the liver. In the AJCC classification system, we do not have a consensus regarding the temporal bone staging system, and hence we follow the modified Pittsburgh staging system for the temporal bone tumors. The T1 is limited to ear canal without bone erosion or without evidence of soft tissue involvement. T2 is with limited external auditory canal bone erosion, not full thickness, or limited, that is less than 0.5 centimeters soft tissue involvement. T3 involves a full thickness bone erosion and involvement of the middle ear and the mastoid. And T4 causes erosion of cochlea, petrocepex, middle ear, carotid, as well as the facial nerve. Palsy also is included in T4. The NM staging is similar to the other staging system of the head and neck. So coming to the clinical features of the temporal bone tumors, the earlier symptoms are quite rare, quite vague, like ear discharge or hearing loss, and hence presentation at an advanced stage is not a very uncommon phenomenon in temporal bone tumors. They can also present with ear canal mass, the facial palsies, vague fullness in and around zygoma, the temporal area, the preauricular swelling. Advanced tumors can present with localized pain, trismus, ataxia, change of voice due to nerve palsies, lower cranial nerve palsies, difficulty in swallowing, or headache. So how to evaluate a temporal bone tumor when it walks into our OPD? As in all other disease, history forms the most important clinical evaluation. A thorough history is always important. Next comes the physical evaluation, a thorough otoscopic evaluation, head and neck examination, audiometric and vestibular examination, speech and swallowing assessment, neurological evaluation, as well as vascular evaluation, like the carotid artery assessment or the preoperative venogram is also important in case we are the planning of surgery and these structures might get involved. So we'll have to have a preoperative knowledge about the structures. So imaging, CT scan for the bony details, MRI for the soft tissue details, and the PET CT for the metastatic workup. So this is a CT scan showing a bone erosion. So coming to the biopsy, the next after the evaluation and the imaging comes the biopsy. The tumors can arise from temporal bone primarily, when in which case the most common histology, as discussed already, is squamous cell carcinoma or the adenoid cystic carcinoma. It can also come from the surrounding skin. Then the histology might be the basal cell carcinoma, the melanoma from the carotid, like a high-grade salivary gland neoplasms. ITF tumors like the sarcomas, etc., can also present with a temporal bone mass. So while assessing, this is an algorithm for planning the treatment schedule. So for that, we need to first assess the performance status as well as assess the site, size, and histology of the disease, and then plan an intent of the treatment, that is curative or palliative. If we go ahead with a curative intent, we'll do all the preoperative investigations or the pre-CTRT workup with audiological and speech and swallowing assessment. For a palliative intent, if the performance status is quite low, then it goes for just a symptomatic care. And if it is advanced unresectable disease, however, with good general condition, we can also go ahead with a palliative radiation or chemotherapy. Temporal bone tumor management is always a team approach. And so representatives from all other disciplines like the head and neck surgeons, the neurosurgeons, plastic surgeons, pathologists, radiation oncologists, all have to be in the loop for a proper management. So coming to the management treatment, as in all other cancers, surgery, radiotherapy, and chemotherapy, they are the baseline of the treatment protocol. So main treatment is always the surgery if possible. The goal of surgery is to remove the disease, to achieve a negative margin, and to minimize the morbidity as well as mortality. So the surgical decision depends on the characteristics of the lesion, that is the site and the size of the tumor, the histology. For example, if it is an aggressive histology like the squamous cell carcinoma with extensive involvement, then maybe sometimes surgery might not be worth it. However, with the same extension, if it is an indolent histology like the adenoid cystic carcinoma, then it is still quite worth resecting. Next comes the exposure and the access needed for a surgical decision and the degree of morbidity which is accepted to achieve the goal. A proper incision planning can go a long way in reducing the morbidity. A proper incision has to allow us to raise the proper skin flap without endangering the vascularity, as well as give a good surgical access. So proper incision planning and an adequate surgical approach can go a long way in reducing the postoperative complications and morbidities. So in brief, we'll go through the surgical incisions. We can plan a preauricular incision if we need to access the parotid, the TMJ, the mandible, etc., ITF, etc. The postauricular C incision, this is the workhorse incision of a temporal bone tumor. This gives access to the mastoid, the parotid, the mandible, as well as to the middle cranial fossa, and a downward extension gives access to the neck. So this is the workhorse incision. Earlier, a Y incision was planned for access to the post-auricular part as well as to the parotid part. But however, with this incision, we see that because of the post-auricular and the pre-auricular incision, the pinna vascularity gets endangered and they land up in pinna necrosis. So now the trend has changed to the post-auricular C incision, by which we can also access the parotid. So this is the post-auricular C incision, and this is the incision in the ear canal. If we drop down that incision with the specimen, then we can very well access the parotid with this post-auricular C incision. As we can see, we have dropped down the ear canal, and then we can access the parotid, the neck, and the middle cranial fossa if needed. The next is the ITF approaches as explained by the Ugo fish. It can be a pre-auricular or a post-auricular incision depending on the access needed. Next is the facial translocation modules as explained by Ivogenica. Among the facial translocation modules, the posterior extended facial translocation module gives good access to the ear, the temporal bone, and the posterior fossa. So coming to the surgery for the temporal bone malignancies, the extent of resection of the temporal bone malignancies, they will depend on the stage of the tumor and the extent of the disease. Usually 3 conventional resection surgeries are usually followed: the lateral temporal bone, the subtotal temporal bone, and the total temporal bone resection. In the lateral temporal bone, that is the LTBR, it's usually used for T1 and T2 tumors and includes resection of the ear canal, the tympanic membrane, malleus, and incus. The boundaries usually includes medially the medial cavity, posteriorly the mastoid, superiorly the epitympanum and the zygomatic root, anteriorly the TMJ capsule, and inferiorly the medial tympanic wing or the ITF. The subtotal temporal bone resection usually historically was used for T3 disease when it invades the middle ear or the mastoid. The specimen includes the LTBR with additional dissection of the otic capsule and the medial bony wall of the middle ear. The boundaries includes posteriorly the sigmoid, superiorly the middle fossa, anteriorly the ICA, inferiorly the jugular bulb, and medially the petrous apex. Next comes the total temporal bone resection, which was designed to address the T4 disease. It includes resection of the sigmoid sinus, the jugular vein, the ICA, the dura, and is associated with quite significant morbidity, which may not significantly improve the survival in such advanced cases. So this is a pictorial depiction. This is the LTBR limit, temporal bone resection limit, and the total temporal bone. We see that we have removed almost everything in the total temporal bone resection. So in the treatment protocol, the lateral temporal bone resection, this is the minimum surgery that needs to be done in any temporal bone malignancies. There are reports about sleeve resection. However, it was found that the recurrence rate with the sleeve resection in T1, T2 tumors can go as high as even 45%. So apart from very small disease, T1 disease with indolent histologies like maybe adenoid cystic carcinoma, usually the standard protocol is that the LTBR is the minimum surgery needed. In T1 tumors, we usually go ahead with surgery. In T2, we usually go ahead with surgery followed by post-op radiation. In T1 and T2 tumors, we usually do not go ahead with a prophylactic superficial parotidectomy if there is no intraparotid nodes in the imaging, because there are reports where they say that the intraparotid nodes in T1, T2 can be as low as less than 5%. So we usually do not go ahead with a prophylactic superficial parotidectomy. In T3 and T4, the surgery, the superficial parotidectomy, and level 2 sampling in case of a clinically node negative disease is the protocol, followed by the post-op radiation, or it can be a definitive CTRT in case the tumor is not resectable. So another debate is on the en bloc resection versus the piecemeal resection. En bloc resection includes the complete resection of the tumor in totality as an en bloc in subtotal and the total temporal bone resection, which involves considerable morbidity. And the piecemeal resection involves removing the tumor bit by bit as if chasing the disease until normal tissue is encountered. Dean et al. Have performed a modified STBR, which consisted of LTBR with local excision of the involved portion of the temporal bone and aggressive skull-base drilling until we get a negative margin. There are reports where they suggest that there has been no significant difference in the survival in en bloc resection versus piecemeal resection, with definitely considerable morbidity involved in en bloc resection if you go ahead with a subtotal or a total temporal bone. So hence now the trend has changed to from en bloc resection to piecemeal resection in advanced tumors, that is T3, T4. LTBR, we usually remove it analog. So coming to resectable versus non-resectable, because it is also quite important to know when not to operate in order to reduce the morbidity. So resectable tumors are usually T1, T2, T3 tumors, and among the T4 tumors, if it is T4 because of the anterior extension to the maybe temporomandibular joint, the parotid, or the preauricular skin, then it is quite resectable. Non-resectable or not worthy to resect tumors will be those with significant posterior, medial, or superior extension with inner ear involvement, gross brain involvement, dural nodularity, or metastatic disease. Coming to the management of neck, the protocol is we do not go ahead with a prophylactic neck dissection in clinically N0, and we go ahead with a modified neck dissection with a clinically N plus neck. But we go ahead with a superficial prophylactic parotidectomy in T3 and T4 disease with a level 2 nodal sampling. As discussed already, the nodal metastasis is always a bad indicator, and the survival drops from almost 60 to 30% in a positive neck. The role of radiotherapy in a T1 disease, we usually go ahead with a single modality, surgery versus radiation, but surgery always shows a trend towards better outcome, with a 5-year survival of even 100% in some literature versus 81% with radiation. In T2, T3, T4 tumors, surgery followed by post-op radiation or chemoradiation is the protocol. Definitive CTRT versus surgery in T3 and T4 tumors, again, surgery followed by radiation has shown a better outcome trend with 50% as compared to 43% in a definitive CTRT. There is no standard chemotherapy regimens till date, except for chemosensitive tumors like sarcomas. There are some literature where they have used TPF regimen as an NACT, where they have found 50% cases turning resectable, but they are very short case series. Concurrent chemoradiation with TPF regimen has also shown quite favorable or quite impressive 5-year survival in some literature. However, if resectable, surgery is always the best choice. Coming to the prognostic indicators, it depends on the tumor histology. Higher T stage, because there is quite a significant difference in survival between T1, T2 versus T3, T4 disease. Neck nodal metastases, distal metastasis, margin status, and preoperative facial nerve palsies, with literature suggesting a drop of survival from 60% to almost 20% if it is if the facial nerve is involved preoperatively. So these are the prognostic indicators which might indicate the future outcome of these tumors. So coming to conclusion, temporal bone surgeries, this necessitates learning unfamiliar surgical anatomy and is technically challenging, and hence a working knowledge of the normal as well as a variant anatomy is quite important for a proper disease clearance. The treatment decision is dictated by the site, the histology, and the extent of the disease. It's also equally important to know when not to operate in order to reduce the morbidity related to surgery. And all said and done, temporal bone tumor management, and for that matter, all skull-based tumor management is very much a team approach, and a dedicated team consisting of oncologists, the speech and language pathologist, the audiologist, and the nutritionists are important for a proper disease management of these kind of tumors. Thank you.
Thank you, Dr. Kabiri, for such an elaborate talk. Now we'll move on to the case discussion part of our Mahamana case discussion series. For this, I would like to invite Dr. Prathamesh Pai, who is Professor, Head Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. Sir has a specific interest in skull-based malignancies and runs a skull-based clinic. Sir, welcome. Dr. Siddharth Shah, who's a head neck oncosurgeon and endoscopic and robotic surgeon at Zydus Cancer Center, Ahmedabad. Dr. Siddharth Shah, welcome. Dr. Kabiri Kakati, who's assistant professor who just presented the talk at the Department of Head Neck Oncology, Dr. B. Barua Cancer Institute, Guwahati. And Dr. Ankit Mahuvakar, who's consultant, head neck surgical oncology and skull-based surgery at HCG Cancer Center, Mumbai. Are all the panelists there? Pai, sir, Dr. Ankit?
Yeah, go ahead.
Okay. So the presenter for today's case discussion is Dr. Bhavya Reddy. She's a fellow at at our institute, Mahamana Pandit Madan Mohan Malviya Cancer Center, Varanasi. Dr. Bhavya, over to you.
Good evening to all. Is the screen visible? I'll go ahead with the presentation now.
Please go ahead.
Yes, sir. Thank you, sir. So I'll be presenting a case of a 46-year-old male who presented to our OPD, who is an agriculturist by occupation, residing in Allahabad, Uttar Pradesh. He presented with the chief complaint of blood-stained left ear discharge since 5 months and growth over left pinna since 2 months. History of presenting illness. Complained of blood-stained left ear discharge since 5 months, which was insidious in onset, scanty, foul-smelling, purulent discharge, which was not relieved with oral antibiotics, which he had sorted from a local doctor, a general practitioner. And he also noticed growth over left pinna since 2 months, which was initially noticed as a small growth which was protruding from the ear canal, later gradually increased to involve the pinna to the present size. The symptom was also associated with pain, which was superficial, mild to moderate intensity, relieved with oral analgesics. The patient also had a history of decreased hearing in the left ear. There were no symptoms pertaining to facial nerve weakness, no history of giddiness, ringing sensation or visual symptoms, no history of headache, fever, nausea or vomiting, no history of difficulty in swallowing, change in voice, decreased or painful mouth opening. There was no history of any other neck swellings or swellings anywhere in the head neck region. No history of cough, hemoptysis, bone pain, loss of appetite, weight loss or convulsions. He's a known tobacco chewer.
Bhavya,
Yes,
can you go back to the first slide?
Yes, sir.
So, when you look at this history, what do you make of this? What are you thinking?
So here we have a male patient who is an agriculturist by occupation who presented with the most with the left ear discharge and a growth over left pinna. And since he does not have a previous history or a childhood history of ear discharge, I would think of any malignant or a benign lesion in the left ear.
Why malignant? And what benign lesions?
So benign lesion could be an oral polyp.
Okay.
Oral polyp arising from the external auditory canal, or pseudoepithelioma or pseudoepitheliomatous hyperplasia arising from the ear canal.
And then why malignancy?
So since there's a short history of ear discharge and also a growth which had rapidly increased to the present size, when he presented to us with a pinna growth of 6 by 5 centimeter size, sir.
So do you expect, 6.5 centimeters?
Yes, sir. It was involving almost the whole lower half of the pinna, including the ear canal.
So generally, if you had a small lesion occluding the external canal, what is more common, a malignancy or a benign lesion?
More common is a benign lesion, sir.
Right. What is the incidence of temporal bone malignancies?
So temporal bone malignancies, especially the squamous cell carcinoma in external ear, is more common in head neck cutaneous malignancies. Around external ear, it's around 15%, and temporal bone, it's up to 5%. No.
When we ask you incidence, it is in the general population.
In the general population, it's 1 in 1 million population, sir.
Right. So it is extremely rare. So yes, you are more likely to be right if you are considering this to be a benign lesion.
Yes, sir.
In contrast, it to be a malignancy. Notwithstanding, this patient has a 6.5 centimeter growth, so it is unlikely to be a polyp.
Yes, sir.
Kaveri, anything else? Siddharth, have they joined? Others have joined in?
I think Dr. Siddharth is not here, sir.
Ankit?
Yeah. In the second slide, when she has mentioned the causes, sort of the etiology, can you just go on to the second slide, please?
Yes, sir.
What is the reason of you asking for headache and nausea and vomiting?
So headache, fever, nausea and vomiting, since the close proximity of the ear canal and also the middle ear to the dural, tegment tympani erosion or dural involvement of meningitis symptoms.
And amongst the negative history, is this the only negative history you have asked, or are there any other negative histories which you have in the next slide?
So some history relating to past history for etiology.
What are they?
So previous history of radiation exposure or comorbidities, considering it could be a benign lesion, comorbidities like diabetes for ruling out malignant otitis externa. But since it's a huge mass in our patient, we would go more towards malignancy. And history of radiation exposure and family history of any malignancies.
As far as I remember, you said that his occupation was a farmer, right? He's somebody
yes,
who is
agriculturist by occupation.
Exposed to a lot of sun.
Yes,
so did you ask for any other actinic keratosis or something as a lesion which will predispose to extensive solar exposure elsewhere in the exposed part of the body?
Yes, sir. There's no significant history pertaining to any other lesions anywhere in the body or head neck region, sir.
Since we are on etiology, can you tell me what are the other factors which can predispose a person to develop temporal bone malignancy?
So most common etiology reported in literature is the sun-exposed areas or the UV radiation. Other than that, we have radiation exposure, which was earlier given like a nasopharynx post-radiotherapy for nasopharynx or intracranial tumors with a latent period of around 12 to 15 years can present with temporal bone malignancies. And certain conditions like burn chondritis and chronic lupus erythematosus, chronic sclerosing lupus erythematosus. And so though literature does mention chronic otitis media or cholesteatoma as a cause, but there's no significant supporting evidence for the same.
Okay. Any idea about an immunocompromised state giving rise to?
Yes, sir. Immunocompromised in a few of the studies done on organ transplant patients, immunocompromised or immunosuppression has been associated with increased incidence of cutaneous squamous cell carcinomas.
Agreed. Yes, great. Go ahead.
Bhavya?
Yes, sir.
Yeah, go on. Kabiri, go on.
So Bhavya, you had asked about a negative family history. Does it have any significance in the temporal bone?
Ma'am, considering it as a primary from the temporal bone, it may not have, but since temporal bone is also known to have secondary metastasis from other sides of the body like breast, prostate, and kidneys.
What is the rate of secondary metastasis to your
less than 5%.
Quite rare, actually. Okay. So
0.2 to 5% has been mentioned in the literature.
Yeah, that's right. Go ahead.
To summarize the history, a 46-year-old male, agriculturist by occupation, a known tobacco chewer with no comorbidities, presented with history of left ear, scanty blood-stained discharge since 5 months, growth over left pinna since 2 months, associated with left earache and decreased hearing. No symptoms pertaining to facial weakness or immediate extratemporal extension or lower cranial nerve involvement. Coming to the general examination, a middle-aged, moderately built male, well-nourished and hydrated, well-oriented with a BMI of 24.5 kg per meter square, an ECOG status of 0. No signs and symptoms of pallor, icterus, cyanosis, general lymphadenopathy, or pedal edema. So should I go ahead with the ear examination?
Yes, please.
So ear examination, on the affected side, left ear, noticed a ulceroproliferative growth measuring about 5 by 6 centimeter involving the left pinna, lower half, parts of left pinna, left concha, tragus, and the lower half of pinna and lobule extending posteriorly to the mastoid area, anteriorly to involve the left parotid region. Inferiorly, the skin involvement was up to the angle of mandible, and superiorly involving up to the inferior crus of antihelix. Left EAC could not be appreciated as the growth was occluding the external auditory canal. Right ear, tympanic membrane was normal, did not notice any growth in the external auditory canal. Bilateral facial nerve examination, there was no evidence of paresis or palsy. Lower cranial nerve examination was normal. Hearing evaluation, left-sided moderate degree conductive hearing loss. Neck examination, there was no palpable nodes. On Hopkins examination, bilateral cords were normal and mobile. Patient had adequate mouth opening. And other nose throat examinations, scalp and spine were normal.
Very good. Go ahead.
Systemic examination did not find any significant findings. To summarize the history and examination, 46-year-old male, agriculturist by occupation, tobacco chewer with nil comorbidities, good built-in nourishment with history of left ear blood-stained discharge and growth over left pinna. associated with left earache and decreased hearing, presented with an ulcero-proliferative growth of 5 by 6 centimeter, occluding the left EAC completely, which was involving the lower half of left pinna and extending to the parotid and retroauricular and mastoid area, with no significant cervical lymphadenopathy, no symptoms pertaining to facial weakness or lower cranial nerve involvement or extratemporal extension.
So what's your diagnosis?
So with the history and the examination finding, I would tell it as we are dealing with an external auditory canal or an external ear malignant lesion.
Any possible staging?
So clinically, according to modified Pittsburgh staging, because there is extensive soft tissue involvement, I would stage it as a T4, N0, and M0.
Right. So how will you work up this patient?
Sir?
How will you work up the patient?
So other than the routine workup for surgical and the general status of the patient, I would go ahead with the biopsy first to confirm the histology. We did a biopsy in this patient, which was reported as moderately differentiated squamous cell carcinoma. And radiological workup was done, which included both HRCT temporal bone and a contrast-enhanced MRI of face and neck. In the HRCT, this is a axial HRCT temporal bone. So the lesion was seen involving the external auditory canal completely, presenting as an exophytic growth outside and involving the pinna. On the medial aspect, the lesion was seen involving the middle ear and up to the eustachian tube. Inner ear was normal. Mastoid as well was involved. And there was evidence of erosion of tympanic part of the temporal bone, posterior, inferior, and anterior walls, and mastoid tips. And also tegmen was eroded.
Can you show the tegmen, please?
So I do not have the axial coronal sections of...
Play this. Yeah. Okay, this appears okay. So why would you want to do MRI in this patient?
Sir, in a ear malignancy, both CT and MRI are complementary. MRI in particular for soft tissue.
In HRCT temporal bone, can you plan this patient's treatment?
So we can plan the treatment based, surgical treatment based on HRCT temporal bone, but since certain indicators like the perineural invasion or dural invasion do...
but there is no involvement of the brain here.
Yes, sir, there's no involvement of the brain, sir, in this patient.
What perineural invasion are you looking for?
Facial nerve involvement, since it's a single most poor prognostic factor, along with the lymph node metastasis.
Facial nerve involved? Is the facial nerve involved?
So clinically, facial nerve was normal. MRI and CT scan.
No. Let's not get into MRI, Bhavya. We are trying to understand when you would do an MRI in addition to a HRCT temporal bone. So your first investigation of choice is an HRCT temporal
bone. Yes, sir.
What in the temporal bone CT scan tells you that this is either an operable disease or an inoperable?
So if there is a dural or intracranial involvement.
So let us start with what is inoperable.
Disease which has extensive soft tissue involvement or disease extending to carotid canal.
Yes. What else?
And subpetrous involvement or
yes. That's right. What else? Anterior involvement.
So inner ear involvement.
You said already petrous apex and you said cochlea and everything,
yes,
middle ear.
Petrous apex, carotid canal, posterior cranial fossa involvement and middle cranial fossa involvement.
No. So inoperable means if it is not, you cannot get a clear margin.
Yes, sir.
So you will not get a clear margin or the disease is into regions which are not resected. Right?
Yes, sir.
So if it is involving the carotid canal, it is not operable. If it is coming into the inner ear, it is not worth resecting. If it is involving the intracranial structures such as brain extensively, it is not worth resecting. If it is coming anterior and inferior, coming on to the infratemporal fossa, which is coming on to the pterygoid muscles and coming medially, it is not what
nasopharynx.
Nasopharynx. So all these are possible on a CT scan. So now tell me when you would ask for an MRI.
So for the extratemporal soft tissue delineation, involvement of parotid, perineural invasion, and vascular involvement.
What vascular involvement?
Carotid and jugular bulbs and
that you already told me it is seen. So
yes.
Please do not get into this standard dialogue of complementary and everything. It
yes.
is okay when you talk about anterior skull base, but when you come on to lateral skull base, there are very defined reasons why will you do a MRI.
Yes, sir.
So you will get all your information when you do an MRI, when you do HRCT. The only indication that you would want is when you are not sure whether the middle ear is involved. You have got a borderline situation where you do not know whether the sigmoid is involved and you want to know whether that's the dominant sinus. And you want to know about the soft tissue involvement, the parotid. You want to know about the lymph nodes. Those are the only other indications. So there are very, very limited indications for doing an MRI in a temporal bone cancer.
Yes, sir.
Ankit, Kaberi?
Yes, sir. I agree. The last indication which I wanted to add was the involvement of the sigmoid sinus, especially if it turns out to be the dominant.
Right. Okay. Go ahead.
So this is axial contrast MRI of the same patient.
Right. So what additional information did this give you?
So in the HRCT, the disease seemed involving middle ear, but middle ear and parotid as well. When we got an MRI done, we noticed that the middle ear involvement, it is not involving the medial wall or the mucosa of the middle ear, or even what was reported as eustachian tube involvement in HRCT was reported as not involved in MRI, sir. It is just a mucosal edema.
Right. So that is very important. What else did you get?
And parotid, superficial lobe of parotid was involved, clearly seen involved in MRI. Sir.
Okay.
And facial nerve was abutted at the stylomastoid foramen where the mastoid tip was eroded but not involved.
Right. Now tell me which other malignancies are common in the temporal bone region, which present like these large masses?
So most common is the squamous cell carcinoma and
apart from squamous cancer.
Basal cell carcinomas and melanomas. Sir. In elderly patients.
Apart from epithelial cancers, which other cancers?
Soft tissue sarcomas, especially in younger age groups, rhabdomyosarcomas and osteosarcomas and other soft tissue sarcomas.
Okay. What else?
Jugular.
Yes.
Minor salivary tumors possible?
Yes, minor salivary gland tumors also. Adenoid cystic is the other most common in minor salivary gland, salivary origin tumors, especially for the temporal bones.
Okay. Benign lesions?
Benign jugular bulb tumors, the tympanic.
Tympanic?
Tympanic plexus or
paraganglioma?
Paraganglioma, sir.
Okay. What about other nerve tumors?
So vagal schwannomas or jugular bulb schwannomas can also present with inner middle ear and EAC extensions.
So which is a more common schwannoma in this region?
So vagal schwannomas.
Vagal will present in the temporal bone. How many vagal schwannomas have you seen present in the temporal bone?
In the temporal bone, there is a neck schwannomas extending, but facial nerve schwannomas are more common in the temporal bone.
Right. So look at what is more common. Okay, so we have the facial nerve, which is most common within the temporal bone and extratemporal bone. So schwannomas, if you ask schwannomas, that should be the first nerve.
Yes, sir.
Okay. Now tell me, how will you know whether this patient has a dominant sinus, dominant sigmoid sinus?
So on the CT scan, it's an antepost sigmoid, or
does the size of the sinus help you?
The position and the size of the sinus and the level of the jugular bulb in the floor of middle ear, sir.
Right. So in this case, which is the dominant sinus?
So he had both sides almost similar, sir.
So then which is dominant? Or both are draining adequately?
Yes, sir.
Okay. So normally the right side is usually more dominant than the left.
Yes.
So your odds are that if you have said it right side is more, it's more likely to be right. Okay. Now tell me, with this information, what's going to be your treatment plan? First stage the patient and then give me a treatment plan.
So it's a carcinoma left external auditory canal. According to modified Pittsburgh staging, based on the clinical and radiological findings, it's a CT4 disease, N0 and an M0.
Yeah.
Since it's a T4 disease, we would, and a resectable tumor, we would, in this case, I would like to offer a lateral temporal bone resection with total parotidectomy, as the superficial lobe of parotid is involved, and auriculectomy, since the pinna is involved, more than half of the pinna is involved, with condylectomy, as we can see the tumor is eroding the TMJ capsule, and a neck dissection level 2 to 4, followed by recon with a spinal PMMC or a free flap, and post-op adjuvant radiotherapy, sir.
Kabir, Ankit.
Yes, sir.
Why level, neck dissection 2 to 4? It's a clinical N0.
Ma'am, clinically N0, but as the stage increases, lymph node metastasis also increases, because it has an extensive soft tissue involvement and involvement over the parotid region, and parotid is also involved. So the chances of occult metastasis in the presence of parotid involvement is more than 20% in lymph nodes, level 2 and 3.
So if you do a level 2 sampling and send for frozen, does that suffice, or we have to complete the neck? Because as per the protocol in N0, we usually do not go ahead.
Yes, ma'am. Ma'am, if we are addressing parotid, and if we are sending level 2 for metastasis, and if it comes as negative, neck need not be addressed.
Bhavya.
And because it's a T4.
Yeah. Bhavya, you said in your MR imaging that the disease was close to the stylomastoid foramen, but the facial nerve was okay.
Yes, sir.
So amongst, you mentioned your entire treatment plan. I agree with the treatment plan. So
Facial
you
nerve.
also mention what would be your plan for facial nerve management? Intro.
So the pre-op planning was done as a facial nerve preserving total parotidectomy for this patient. Intro-op, if there is involvement of nerve, or if there is any change in color or thickening of the nerve, we may have to sacrifice the nerve.
Okay. So pre-operatively, when looking at the patient's disease extension, as well as looking at the scans, the MR especially,
yes,
will
sir.
you be able to judge that, yes, I would be in a position to save the nerve, or I would be handling the nerve upfront before I do the parotidectomy at the stylomastoid foramen to see for the operability and trace the nerve backwards rather than going into the parotid?
Yes, sir.
Any idea of doing that?
Sir, in the MR, we did not notice any perineural enhancement or thickening of the nerve. So we could trace the nerve back to the geniculate ganglion.
Bhavya.
Yes, sir.
Is this a skin cancer?
Sir, I didn't get the question, sir.
Is this a cancer of the skin rather than the external canal?
Sir, as the patient in this present case, he gave a history that the mass initially was protruding out of the external auditory canal. And the epicenter of the disease also appears to be an external auditory canal, according to radiological investigations. If this history was not there, we could have taken it as a pinna malignancy instead of an external auditory canal.
So what I wanted to ask was, is this a malignant? You said that the middle ear is free.
Yes, sir.
Patient has no facial nerve palsy. The whole mastoid, everything looks like a chronic mastoiditis.
Yeah.
There is no erosion of the external canal bone as well. There is no involvement of the TM joint bone, in spite of such a large disease.
So there is
erosion of the
anterior wall and involvement of the temporomandibular joint capsule, sir. But the condyle is not eroded. Bone is not eroded, sir.
Right. So all these factors point that point towards it being a skin disease rather than a mucosal disease. So
Yes,
why I'm trying to make a point is, if you have a disease coming from the middle ear, or it is associated with the mucosa, and it's a squamous cancer, you would have more symptoms related to the ear, unlike in this case where it is arising from the skin, and hence it is not invading and not involving a lot of structures.
yes, sir.
This differentiation has to be made, and it has a bearing on your treatment. Like you said, you will do auricular resection, you will do external canal resection, you will do a condylectomy, you will do a parotidectomy. All these are very extensive resections for a skin cancer. For a skin cancer, you're more concerned with getting a margin and the base rather than doing more extensive resection. So we need to understand this fine difference.
Yes.
And our counseling and our planning makes a big difference. Now, I agree with you that the minimum surgery that you'll do with be an lateral temporal bone resection.
Yes,
but I do not agree that you will need to do a condyle resection in this patient just because it is relevant to the condyle. You also need to understand this patient has normal mouth opening. Patient has no other symptoms other than the swelling, and he is well nourished. He is not being affected.
Yes, sir.
So this really drives home the point that you need to consider doing less rather than more. And intraoperatively, when you have the possibility of frozen section, it would be advisable to do less. Of course, for a T4 cancer, you would do a parotidectomy because it is the first echelon of lymph nodes. You would also need to consider doing a posterolateral neck dissection in this patient because of the involvement of the skin inferior and posterior to the canal,
Yes.
to the pinna. So you would be safer if you had said I would have done a posterolateral neck dissection, including the suboccipital group of lymph nodes as well, in order to understand, in order to complete your neck management. Why would you want to do a free flap in this patient?
Sir, the first option.
What are the reconstruction plans possible in the lesions involving the external canal?
So for this extensive lesion, because the skin involvement is more, we were planning for a free flap or a PMMC if the reach is possible.
So is it? It's not possible.
So in this case, we did do a spiral PMMC, sir.
No, where does the PMMC reach?
Sir, for cases below the level of zygoma, PMMC would suffice, sir.
Right. So this is well within the reach of your spiral PMMC.
Yes, sir.
So first option would be to do a spiral PMMC. If it was a smaller lesion, what are the other forms of reconstruction?
Sir, if it was a smaller lesion and total auriculectomy is I
don't agree that you'll do a total auriculectomy. You don't need to remove the helix. You don't, whatever is involved lower down, conchal bowl, concha, the pinna, all that can go, but not necessarily the helix. So how will you reconstruct? What are the other methods of reconstruction?
Sir, local flaps can be used.
Like?
Submental flap.
Yes.
And a split skin graft also was used earlier, but nowadays it's not.
No. Submental flap is a pedicle flap. What are the local pedicle flaps are possible?
Supraclavicular or a DP flap, sir.
Supraclavicular flap. Submental artery flap. These are two commonly used flaps. Which are the other pedicle flaps apart from PMMC?
So, superficial temporal artery based flaps or a scalp flap.
More cosmetic. Have you heard of trapezius myopia?
Trapezius myopia, yes, sir.
So that is also a very suitable flap in this region because you're already doing a postlateral neck dissection.
Yes, sir.
Okay. How will you give? What adjuvant therapy would you plan?
Sir, adjuvant radiotherapy in this patient. As it's a T4 disease, even though it is N0 and extensive soft tissue involvement. Post-op, we did get negative margins, sir, in this patient in the final HPR report.
Show the HPR.
Sir, I have not added the HPR report.
Not added. Now tell me, in this patient, how will you plan the rehabilitation?
So rehabilitation for hearing and also rehabilitation neck, since we have addressed the neck for neck and shoulder physiotherapy.
So you have done an auriculectomy?
Yes, sir.
So how will you rehabilitate him for that?
So prosthesis, skin match prosthesis are available.
And
do we have anything called as a stick-on prosthesis
Stick-on
available?
prosthesis or even grafts.
Anything else? Do you have any implant-based prosthesis?
Osteo-integrated implant?
Not aware, sir.
So you can also do an osteo. Ankit, you want to tell?
Yeah, the thing is, the reason why sir mentioned that we can actually preserve the upper half of the ear is because you have to realize if the patient is a person who wears a spectacle, that upper half of the helix will actually help him balance the spectacle properly. Secondly, there are multiple options available. Prosthetic implants are there. Whenever we are planning to do surgery for him, and in future we plan to do an osteo-integrated implant rehabilitation, there are studies which have shown that we can actually put in the implant and then subject the patient to RT. The implants does not hamper into the post-op RT of the patients. There are some studies which go against that. But once the RT is done, 3 months post the RT, we can actually give the patient implants which are magnetic, which actually sticks onto the osteo-integrated implant. They are ferromagnetic implants, and the patient can actually roam around without any issues.
Right. I think that's very important. How will you rehabilitate his hearing?
So hearing, it can be done during the same stage sitting or after 3 to 6 months of the first surgery using osteo-integrated implants or BAHA bone conduction aids, or even contralateral routing of sound signal aids.
In this patient, does he require rehabilitation for hearing?
So he had significant conductive hearing loss complaint clinically. So
what was his TTA?
Sir?
TTA findings, audiometry.
So we could not get the audiometry done. The moderate conductive loss, what we did was
on your tuning test. What readings was positive or negative on the other side?
Sir, the right ear had Rene's positive and it didn't have conductive loss. Only left ear had moderate degree or only on tuning fork test.
And Weber?
Sir?
Weber's test?
Weber's was lateralized to the same side, sir.
Okay. So then, does he require rehabilitation?
Sir, if in the post-op period, if he has a significant complaint regarding the hearing on the left side, then he can be given cross or he can be given osteo-integrated implanted hearing aid or BAHA.
You are
complaints.
You are the treating physician. How are you going to plan? Do you think he requires hearing aid or not? Does he require BAHA or not? There's everything is possible.
Yes, sir. So if the patient has a significant difficulty, then it can be offered. Sir?
Ankit?
What was the status of the middle ear mucosa, middle ear ossicles, the ossicular continuity?
So middle ear
when you had opened up the middle ear?
Middle ear mucosa was edematous but normal, not infiltrated by the tumor, and malleus was eroded, but incus and stapes were intact, sir.
So you did a lateral temporal bone dissection in
yes,
which
sir.
you
malleus
have taken down the malleus and the incus. Stapes was intact, footplate was mobile, correct?
Yes, sir.
Okay, so what kind of tympanoplasty would you like to do for this patient? That's what sir is asking. And what kind of tympanoplasty, type 1, type 2, type 3, such that you'll be able to give this patient lesser degree of conductive hearing.
Total auriculectomy. So
does auricle actually play a significant role in conduction of sound?
So auricle and the external auditory canal do play. But in this case, yes, placing a graft on the stapes footplate or the stapes head may help for better bone conduction if we are doing a bone implanted hearing aids at a later stage.
Right. So hearing mono-aural hearing is good enough, serviceable. It doesn't really require rehabilitation. There's a lot of debate whether you should do it during surgery. There are a lot of cost implications and there are a lot of maintenance issues and patient follow-ups. So the patient you need to assess whether the patient has a normal hearing on the other side. And if the patient is not going to be disabled due to that, then he doesn't require any form of rehabilitation. You have to be very, very specific. You can't say, I will do this and I will do that. In this patient of yours, what is the plan? So we need a good reconstruction plan we need rehabilitation for him, for hearing, for the external appearance. And as Kit rightly said, if you preserve the helix, it serves for even prosthesis. You can even give a better prosthesis because it looks more natural. So all in all, when you're planning the surgery, you need to pay special attention to all this further on after the patient has completed treatment. So a full 360-degree view of the patient's outcomes has to be understood.
Sir, if I may,
can I add one thing?
Query, sir.
Ankit?
Yeah, I just want to add one thing. We need to always plan all these things, but sometimes there is a query, like for example, this side of the year or that year would have been the only functioning year which the patient had. You realize we can call that as a precious year. Yes. And we have to decide our treatment plan such that we can give him maximum near normal status of life. Okay. And one more thing I wanted to ask, you had mentioned in your imaging that the tegmen was eroded. I just wanted to know what was the intraoperative finding of the tegmen? Was it completely eroded, partially eroded, focal?
The there was about a 4 millimeter erosion in the tegmen tympani, but there was no neural infiltration.
So a tegmen erosion, eroded tegment is a contraindication for conventional, for a lateral temporal bone resection done conventionally, like an en bloc resection, or need to extend the surgery?
Sir, if there is a tegmen tympani, extended lateral bone resection can be done where after the conventional LTBR, a piecemeal resection can be done around the erosion site until the normal tissue or the normal dura, if at all, if involved. In this case, if it was not involved, it could be because of the tumor pressure necrosis.
Suppose you had to take the facial nerve, say for example, anti-stylomastoid foramen, because it was 360 degrees completely engulfed by the tumor. Yes, what extra would have you done? What things could you do to manage that out?
Sir, if the nerve can be dissected off the tumor, even though if it is engulfed and the nerve appears healthy, the nerve can be dissected and delineated till the first geniculate ganglion. And if the nerve is healthy, you can do a facial nerve translocation and remove the tumor.
Whenever you answer a question on facial nerve or important structures, which is dicey, whether you need to cut it or take it out, the first answer should be, you should be R0 everywhere else. Only then you are allowed to cut a nerve. Yes, there is no point you cutting the nerve if you have left disease somewhere near the near the stapes, foot plate, near the inner ear, and then taking off the nerve. Okay. Yes, so yes, nerve to be cut only and only if you are R0 elsewhere. Whenever you are dissecting a nerve, you need to have frozen control available. It is always better for you to identify at least one important branch of the terminal branch, that is the branch which supplies the orbicularis muscle. To identify the nerve, get the proximal stump, to get the distal stump. For you to get the proximal stump, you need frozen control. And if possible, you need to do a grafting, intra-op grafting. Yes. And definitely such patients in which the facial is sacrificed, you will have to do an intraoperative lateral tarsorrhaphy to prevent exposure keratitis. Okay.
Yes, sir.
Good. Kaveri, any questions?
Not much, but just going back to the basics, it's a clinically T4, but as Sir and Ankit has said, we can, it is not conventionally the routine of en bloc resection does not hold true here, because if we would have gone for an en bloc resection, as already discussed, then it would have been quite a lot morbidity for the patient. So in this kind of tumors, that concept of piecemeal resection has come up because this spares quite a lot of morbidity, and hence this trend of piecemeal. So already discussed, but just repeating that we have to personalize or customize the treatment according to the site, and not just going for a en bloc resection.
Okay.
Well done, Bhavya.
So can I add one more point, sir?
Yes.
Yeah, please.
Bhavya, you said the staging of this patient was T4. Do all T4 behave in a similar fashion, or do we have some T4s behaving better than the others?
Sir, if it's a squamous, it depends on the histology, sir. Again, if it's a squamous or...
all are squamous. All are squamous. So I'll give you an example. The same patient is, say, patient A, and the other patient, patient B, is classified as T4 because of involvement of facial nerve. The skin is free. Which will fare better?
So the one without the facial nerve involvement has a better prognosis.
Okay. Patient A has got T4 disease because of facial nerve involvement, and the other patient, patient B, has got is T4 because of dural involvement. Who will fare better?
So again, the dural involvement, if it's resectable, there's a study by Morris et al. Where they have noted even with the dural involvement, if it's a resectable tumor, local recurrence rates are far better when it's compared to the facial nerve involvement.
If you are aware, there is a recent paper by the Immunology group, it's the European group, Piori, Nicolai and all. They have come up with a prognosis.
Class. I think I lost our monitor.
Yeah, so they call it the Padau system, in which they have classified the tumors and they have given a numerical value to each. And a score of 5 and above says that there is a high propensity for local recurrences, the short disease-free survival, T4, 5 years survival in majority of the papers is 0. So I would suggest you go back and read that Padau's scoring system.
Okay, sir.
Just adding on to whatever Ankit has said about the T4 tumors. In general, any tumor is true in all the head and neck tumors as well. Any tumor which is anterior. For this patient, the T4 was because of the anterior extension. So yes, that made it a good prognostic marker for the patient. However, if it would have been a posterior extension, if it would have been a medial extension to the pectorals, the posterior extension to the posterior fossa, then those T4 tumors are not good. And as Ankit has said about the facial nerve, that is already known bad prognostic, because all T4 does not behave equally. Anterior T4s have a better prognosis, and histology is definitely indolent histologies, adenoid cystics, and all those things. Even with quite an extensive tumor, which would have made a squamous cell histology unresectable, might be worth resecting in case of maybe adenoid cystics. So size and histology are very important prognostic indicators while planning for a surgery.
No, I'm okay.
Yeah, why? Just one last question.
Yes.
Yeah, Bhavya, you said that there are tumors which metastasize to the temporal bone. You said they are basically prostate and breast. Why does prostate metastasize to the temporal bone? Do we have any specific pathway?
Sir, it's through the vertebral venous plexus. It metastasizes to the
There is a name for that. Yeah, so there is a name for that venous plexus. You know that?
No, sir.
It's Barton's venous plexus, and the specialty is that these are valveless veins. So majority of the retroperitoneal structures, they do metastasize through that veins, through flat bones, as you mentioned, flat bones of this. When we give radiation to the temporal bone, do we expect any element of sensory neural hearing loss to happen?
So post-RT-induced sensorineural hearing loss has been reported as one of the intermediate and late complications of RT to temporal bone, and even RT as post-RT nasopharynx as well, sir.
Okay, great. So now tell me, what is the threshold limit of the cochlea? If the radiation dose shoots over that. Yeah, read that. What are the other late complications of radiation, especially in a temporal bone malignancy?
Sir, osteoradionecrosis of the temporal bone is one of the common late complication which has been reported.
Okay. Anything else? Some patients, say, for example, 10 years down the line, he was stage 2, he received radiation, presented with altered consciousness, comes up with seizures.
Sir,
something called temporal lobe necrosis. How frequently will you see this patient in your post-op, say, for example, post-RT? How will you manage the follow-up? How frequently would you like to see the patient? And if yes, what imaging and how frequently will you image the patient?
So follow-up post-RT at 6 weeks, and imaging would be done at 3 months, sir.
Okay, so what would be that first imaging which you like to get?
So HRCT temporal bone or a PET scan if suspecting distant metastasis, but since the distant metastasis in temporal bone is incidence is lower, we can go ahead with the HRCT temporal bone and neck for loco-regional recurrence.
If you are given an option between HRCT temporal bone and an MRI, what would you prefer and why? Cost being not an issue.
Post-resection, MRI could be a better option than CT scans. Soft tissue residue or neck node metastasis.
Rather than neck node metastasis, whenever you do a temporal bone surgery, you would have seen this patient getting operated. That once we are done with our surgery, we do pack the cavity with fat.
Yes, sir.
Correct?
Yes, sir.
Fat will serve as a natural contrast. Whenever you do an MR, that fat will give you a natural contrast vis-a-vis just doing a CT scan, which will not be able to give you that level of contrast, that level of soft tissue delineation between thing like a benign thing like fat and residual disease or recurrence. Correct me if I'm wrong, sir.
You're absolutely right, Ankit. Go ahead. So, Ankit, Kabiri, how has Bhavya done?
Very well.
Very well.
Very well.
Good. Very good.
Thank you, sir. Thank you, ma'am.
Thank you very much.
Thank you, sir. Thank you, Bhavya. Thank you, Kabiri.
Thank you, sir.
Thank you all the panelists. And it was a great presentation. And thank you, Paisar. Thank you, Dr. Ankit. Thank you, Dr. Kabiri. We'll meet again, hopefully 15 days later with a different topic. Thank you.